hello, amici, ragazzi.
Hi guys.
Hello, everybody. Hello, everybody. So, Nisa, you just came back.
Yes, from
Yeah.
Bologna.
Yeah, from Bologna. Yeah. Great. I know there was a meeting over there. Yeah, good.
Maria Pia's meeting.
A what?
Yes, a meeting in Bologna. Yeah, where speaking about inflammatory, but basically, more or less everything, a little bit of everything, right?
Yeah, exactly. And Enzo was also there, and Claudia.
Yeah.
It was a good meeting.
And where was Debbie? Debbie was not there?
Yes, I'm becoming old. They prefer to invite younger people, you know?
Well, apart from that, there are so many places you can be, my friend.
Yeah, for sure.
Wow, Sebbi is recalling us to keep on time. And now, question of the week. How dangerous is squamous cell carcinoma? Not at all. Somewhat. Quite a lot. See.
In the meanwhile,
Yes.
where does this echo come from? Wow, look at the vote.
Incredible.
Yeah.
Yeah. Of course, we show our sympathy and love to the one guy voting.
Not at all.
Yeah.
Yeah.
It was
Yes.
one guy, yeah. So I mean, we love you.
Yeah.
Yeah.
We love you because we agree with you. We agree with you. We would like that SCC is not dangerous at all. Yeah.
Really? We do agree?
I would agree that we all hope that this is the case.
In terms of hopes, yes.
No, not only in terms of hopes, but also realistically, if you're able to diagnose all SCCs when they are small papules, then they are not dangerous at all.
True.
We have solved this echo problem. Do you also hear this? I guess.
Yes, I do.
Yes, a little bit, yeah.
Yeah, I don't know where it comes from. In the meanwhile, we have to say hello to Spain, to Argentina, to UK, to Hungary, Algeria, Turkey, Libya, Chicago, Germany, Londra, Turkey, South Africa, Serbia, Ukraine, Ecuador, Mexico, Macedonia, Beirut, Armenia. And that's it only for today.
Yeah, but you missed all the previous ones. Brazil, France, Uzbekistan,
Go.
Reggio Emilia,
Go.
Netherlands, Paris, Romania, Sweden, Brescia, France, Riga, Melbourne, Canada, Madrid. Yeah, and that's it basically.
Awesome. Brazil, Slovakia, Vilnius.
Yes. Lima, Armenia.
Okay.
Kosovo.
Next, let's say next episode is episode number 10, so we do them up. Next episode.
Exactly. Yes.
Okay.
Let's do them up.
Wonderful.
Perfetto, ragazzi. So today we speak about squamous cell carcinoma.
Mainly treatment, but not only, but mainly treatment. So
yes.
Or not, Konstantinos? No,
No.
Okay. So it's your to continue from last week.
Exactly.
Okay.
Yes, it's Costantino to be continued.
Yeah, it's TBC.
Yes.
Okay.
Vai Costantino.
Before I want to ask the question of the week to each one of you. Emilios, how dangerous is SCC?
Could be very.
Could be very. Okay. Sometimes.
Yes, sometimes.
Zepi?
5%. Yeah. It's dangerous in 5% of cases.
Nisa?
Depends on size, differentiation, and localization.
I like your answer. But continuing what we were discussing on the previous week, in essence, we were talking about actinic keratosis and the risk of their progression to squamous cell carcinoma. The thing is that we don't actually know. Actinic keratosis, or actually not even actinic keratosis, a sun damaged field can progress to an invasive squamous cell carcinoma, even low differentiation, so an aggressive squamous cell carcinoma, even from nothing, like just from sun exposed skin. The progression model is not linear, unfortunately, because if it was linear, we would have a better understanding and a better management of the situation. You see an actinic keratosis, you treat it, the cases of it turning into SCC diminishes. Unfortunately, that's not the case. So here we have a squamous cell carcinoma in situ. We see the beautiful glomerular vessels along with the scaling. I think this is an archetypical Bowen's disease. We discussed about this. And we can also get pigmented squamous cell carcinoma in situ, like Bowen's disease, which has these linear projections at the edges along with the dots in a line that have been described beautifully. Here we can see the dots in the line and the linear projections in the periphery. Actually, Emilios and Nisa and Jeppy, I was just thinking that this is something that I have never published, but I think we should. That squamous cell carcinoma in situ, so pigment Bowen's, has this keratotic star-based pattern, which hasn't been published, I think, but it is exactly that. It does like this, but doesn't do much more.
I think I've heard it somewhere.
I think I've told you before.
From you. Okay,
Yeah,
good.
most likely.
Yeah.
So, dermoscopic criteria for early detection of squamous cell carcinoma arising on an actinic keratosis. This is a beautiful paper by Chrysza, which actually highlights that the presence of vessels along with keratotic plaques indicates the progression of a squamous cell carcinoma, of an actinic keratosis into squamous cell carcinoma. I'm picking up from where I left last time. And here, ulceration is also very helpful for the diagnosis of an early invasive squamous cell carcinoma on the surface of an actinic keratosis. Invasive squamous cell carcinoma. This is the actual problem. This is the thing that we're dealing with. And so this year in the US, I'm talking about the US because we have a little bit more data and more organized data via the SEER database. 110,000 melanomas will be diagnosed, and approximately 7,500 people will die of melanoma. But for squamous cell carcinoma, we do not have the numbers. Based on the really nice projection study by Loma in 2014 and 2016, it's calculated that 5.4 non-melanoma skin cancers will be diagnosed, and approximately 1.5 million of them will be squamous cell carcinoma. And although squamous cell carcinoma has a low mortality rate, based on sheer numbers, and as Debbie was saying, 5%, 1 to 3%, according to literature, will be very dangerous and can lead to death. But if you have 10 times, 15 times more squamous cell carcinomas than melanomas, it makes sense that probably more people die of melanoma of squamous cell carcinoma compared to melanoma. What do we know about squamous cell carcinoma? It develops in elderly patients. It's difficult to diagnose sometimes, often large in size, often problematic locations, that always a problem, and not such a good prognosis. It represents 20% of skin cancers. In Caucasians, it has risen 6 times in male and 10 times in female in the past 30 years. The 5-year survival is 90%. 2 to 4% of people die from squamous cell carcinoma. Sorry about the Greek. The question is, how do we diagnose timely squamous cell carcinoma? And the answer is almost always dermoscopy, since we're in dermoscopy happy hour. One of the first studies that described squamous cell carcinoma eloquently was this one by Cliff in 2012. And then we have the one by a guy, I don't know, A. Lalas, Andreas Lalas. Who is he?
Yes.
The clinical and dermoscopic features of invasive cutaneous squamous cell carcinoma depends on the histopathological grade of differentiation. And what do we see here? White. SCC is a white tumor, where at least part of squamous cell carcinomas is a white tumor. Here we see a keratinizing tumor with a lot of white homogeneous areas along with some vessels. And I think that instinctively we can immediately recognize a well-differentiated squamous cell carcinoma. White color, keratin, structureless areas, circles, white circles, which corresponds histopathologically to abnormal keratinization along the hair follicle. Whitish halos, in essence, it's the same histopathologic correlation. And this is an archetypically well-differentiated squamous cell carcinoma. You can see the keratin, you can see the white amorphous areas, along with the white keratotic, the white hair follicles, and the white halos around the hair follicle. So here we have a very stereotypical, well-differentiated squamous cell carcinoma. The mortality rates from well-differentiated squamous cell carcinoma are low, although here we have one bad prognostic factor. Well, actually two. What's that, Nisa?
SCC?
No, 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 no. What are the bad prognostic factors? It's location and size. It's a big tumor on the temple.
Yeah.
Yeah, big. It's not that big, but is it?
Yeah. No, it's well differentiated. So I think it's good. It's not on the ear, on the lips, so the location is okay. And I see some keratinization clues, so it's a well differentiated SCC. So the metastasis risk is low here.
It is lower, but it's more than 2 centimeters, so it rises a little
Yeah.
bit. However, but as Nisa said, yes, this is a well-differentiated squamous cell carcinoma. The risk of metastasis is comparatively low. However, we have these ugly red tumors. And
Yeah.
what do we see here?
Poorly.
Pardon me?
Poorly differentiated.
Exactly. So a poorly differentiated squamous cell carcinoma, that how does that translate biologically? The cell becomes more ancient, more raw. So it loses its capability to produce keratin. This translates into more aggressive behavior. That's why it's an aggressive tumor. It's a red tumor that causes a lot of neovascularization. What do we see here? Ulcerations. We see a lot of new vessels. And this, by definition, is a bad tumor. And very commonly, we come across these tumors in elderly individuals. The differential diagnosis includes, I mean, look at the clinical and look at the dermoscopy as well. This could easily be either an amelonotic melanoma or a Merkel cell carcinoma or a low differentiation squamous cell carcinoma or an atypical fibroxanthoma. I don't think that dermoscopy can be very much of aid in these cases. The only thing that we need to do is to remove these tumors as soon as possible, because that's the only way that we can help our patients. Likewise, here, an ulcerated tumor with a lot of neovascularization, a bad tumor. Here as well, you can see the amount of new vessels. You know that this is a bad cancer. So, of course, it maintains some elements of keratinization. So we still maintain good differentiation. But as you come to the edges, what do you see? A lot of new vessels, a lot of ulcer, a lot of red. This is a bad sign. And this is a sign that we should remove the tumor as soon as possible. And here we have the two edges of the spectrum. We have the well-differentiated squamous cell carcinoma and the well-differentiated and the poorly differentiated squamous cell carcinoma. These are different beasts, different tumors, and they should and they are treated differently in terms of monitoring, in terms of follow-up, and in terms of managing our patients. Histopathologically, a well-differentiated squamous cell carcinoma has layered squamous epithelium. Sorry, in normal epithelium, we have a well-differentiated layered squamous epithelium. Then we have the markedly hyperplastic but well-differentiated epidermis and a squamous papilloma and well-differentiated SCC with numerous keratin pearls, which correspond to the white plugs that we saw before. And the poorly differentiated SCC has disorganized trabecular, marked inflammation, and nest of neoplastic epithelial squamous cell carcinoma. So the vessels, exactly because it's a very chaotic tumor, a very aggressive tumor, are way more in a poorly differentiated compared to a well-differentiated tumor. In terms of scales and white circles, white halos, and all those things, we can see that in poorly differentiated, we lose all those keratinizing features that we see in well-differentiated squamous cell. The recurrence rates range from 3 to 31%. And as I have said before, when you see all these huge differences in terms of percentages, the answer is that we have no clue. Why do we have no clue? Because a lot of SCCs go undiagnosed and they come to us when they're already metastatic. A lot of people from remote areas do not get the treatment that they should earlier on. And also because our recording system, most recording systems around the world, do not record non-melanoma skin cancer because of the quantity of these tumors. And distant mets, in this were consistent, is approximately 1 to 3%. 2% is a good metric. And if we look at the NCCN guidelines for squamous cell carcinoma, we can extract the risk factors for squamous cell carcinoma, immunosuppression, and hematologic malignancies, both for the development as well as for a poor prognosis. The location, lip, ear, as Nisa was saying, size larger than 2 centimeters, depth, breast lobe depth. It's a tumor, and this is something that we have been failing. I think we're getting better. One of the major challenges that we need to do is to create homogeneous and consistent histopathological reports. So the histopathological reports sometimes come back with breast lobe thickness for basal cell carcinoma. It makes no sense. But for squamous cell carcinoma, the breast lobe depth does make a huge impact in terms of the outcomes and the monitoring of the patients. So depth more than 2 millimeters, this is breast lobe depth, and poor differentiation.
And don't forget perineural invasion.
And perineural, I'm sorry, yes. I forgot to put it here for some reason.
Yeah. No, it's here.
Huh?
It's here.
Yeah. So low risk, well-differentiated type location and sun-exposed areas, except ear and lip. We manage with 4 to 6 millimeter margins. High risk is periorificial zones and scars, diameter larger than 2 centimeters. Immune suppressed patients, so we should go with an excision of more than 6 millimeter margins. And the high risk are non-differentiated or desmoplastic, acantholytic type squamous cell carcinomas with the presence of perineal invasion. And then we should go with an excision of more than 6 millimeter margins. So in low risk squamous cell carcinomas, we approach the patient with an ordinary excision with margins 4 to 6 millimeter clinical margins, whereas in high risk squamous cell carcinomas, we should proceed as soon as possible to the excision with larger margins reaching up to 1 centimeter, and adjuvant radiotherapy can be considered in case of nerve involvement. Follow-up for patients with squamous cell carcinoma. For the first 2 years in a low-risk squamous cell carcinoma, clinical follow-up every 6 months, and after second year, clinically every 12 months, every 1 year. Whereas in high-risk squamous cell carcinomas, the indicated follow-up period should be every 3 months, and with regional ultrasound of the regional lymph nodes every 6 months, and then follow up for up to year 5 every 6 months. This is the guidelines of the EADO for the management and approach to squamous cell carcinoma. I will not go into deal to this because I've already been speaking for 20 minutes, so I'm going to move a little bit faster. And here we have, obviously, a tumor, which on dermoscopy has still maintains the keratinizing features. This is most likely a well-differentiated squamous cell carcinoma. And I think that a take-home message should be that a well-differentiated SCC is white, whereas a poorly differentiated SCC is red. This is a bad tumor. The differential diagnosis are the aforementioned AFX amyloidotic melanoma, Merkel cell carcinoma, and low differentiation SCC. And our approach should be immediate excision, first with close margins if we do not have a biopsy, and then re-excision with appropriate margins based on the diagnosis. Immediate excision is the message. And I will stop here, I think, because the presentation, we could talk for hours upon hours, but
Well, but it's only 7:20, so 7:25. So if you like to keep going for 5 minutes and then we keep.
oh, by all means. So here, immediate excision. And here we're discussing again what we were saying before. Squamous cell carcinoma, adnexal carcinoma, Merkel cell carcinoma, melanoma, malignant fibrous histiocytoma, and atypical fibroxanthoma, they all have the same look. A red neovascularizing tumor, so a bad tumor that should be excised as soon as possible. The most difficult diagnosis, the differential diagnosis of well-differentiated SCC is, of course, the irritated seborrheic keratosis. In irritated seborrheic keratosis present, as we all know, with milia-like cysts, whereas in squamous cell carcinoma we have white circles, as we see here. And here we have a very good example. So what is this? Traumatized subcare or an SCC?
SCC.
SCC, agreed. We see the white circles, and this is very indicative of the diagnosis. White peripheral circles, very indicative for squamous cell carcinoma. Here we have another case. What do you think this is?
SCC.
Excellent, because the white perivascular halos is a clue for a keratinizing tumor. They can be found in SCC, in seborrheic keratosis, and in common wart. But here, I think the clinical is way more helpful for the diagnosis of SCC compared to an irritated seborrheic keratosis. Also, this indentation of the skin is very indicative for squamous cell carcinoma. In squamous cell carcinoma, the white halos are not symmetrically distributed. They're kind of chaotically distributed along the lesion, whereas in an irritated seborrheic keratosis, usually we'll find an even distribution both of vessels and these whitish halos around the hair follicles. Here,
SEB-K.
SEB-K.
Okay.
Excellent. And for hyperkeratotic lesions, what we should keep in mind is that this image on dermoscopy tells us nothing. What we need to do is we need to remove the thick scale crust and look underneath the surface. So here, what's the diagnosis?
SCC.
Exactly. So this is not just a hyperkeratotic actinic keratosis, a grade 3 actinic keratosis. This has already infiltrated, and you should probably not proceed with a topical destructive treatment, but proceed with surgical excision. Here as well, what do you make of this?
Now,
Or, yeah, most likely SCC.
crustectomy. Yeah.
And
Yeah, SCC.
this is a moderately differentiated squamous cell carcinoma, and we should proceed with excision as soon as possible. Here as well, this is a typical actinic cheilitis. But if we remove the crust, what do we see? These vessels, this neovascularization, That's indicated.
SCC.
That's indicated for squamous cell carcinoma. So here also we should proceed with excision instead of proceeding with a cryotherapy or CO2 laser or whatever everyone is familiar with in the treatment of actinic keratosis. And I think I will stop here since it's 8:30, and I think we can proceed with comments.
Very good, very good.
Great.
So there are a couple of
Great.
questions and comments.
There is a question about mitotic index. Is it important in SCC or not really so much?
Excellent question. So far, it has not been recorded in any guidelines that mitosis is important. Differentiation, location, vessel thickness, and size, clinical size, and perineural invasion are the most important predictive factors. But I think that as we move forward in refining our criteria, they could be, because I mean, what is mitosis? Mitosis is a sign of aggression.
Yeah.
So it could be, especially in this gray zone. So if you have a low differentiation squamous cell carcinoma, it's a horrible cancer. If you've ever seen like histology of low differentiation SCC, it's just a chaotic tumor with small cells, but it's separating, mitosing all the time. So I don't think that there it will play a very big role. But I think in the white, in this gray area of well and moderately differentiated SCCs, it could potentially have a role, indicating the aggressiveness of the tumor. Of course, still we have no data. I'm just speculating, but this would be my speculation.
Yeah.
How often do you see spontaneous regression in keratoacanthomas? That's a common question we often discuss. Theoretically, it's possible. Practically, we don't see it so often. True. We don't see it so often, but we don't let it happen also because
we excise it.
Theoretically, in my view, all keratocatomas should go in through spontaneous involution, theoretically. But the problem is that how to differentiate these two hands is not so easy. And
It's
therefore,
impossible. Yeah.
So the problem with KAs is that they look exactly the same as a well-differentiated squamous cell carcinoma. Of course, you can speculate that's SCC with KA differentiation or a KA because the classification has changed so many times. I think that we don't let them involute. Supposedly, according to the literature, 10 to 30% of them should involute spontaneously. I only have maybe 3 cases that by the time their surgery was planned,
yeah,
by the time they came back, the tumor was gone. But I have 3 of those.
yeah.
Many other questions. Have you encountered keratoacanthoma-like metastasis of adenocarcinoma of the lungs? Well, I don't think that this is a frequent pattern of metastasis, but metastasis could sometimes be very strange. Still about keratoacanthoma, would you consider keratoacanthoma like squamous cell or squamous cell like keratoacanthoma? Okay, that's the discussion we did already. It's never-ending story. Wow.
Oh.
Elvira.
Sebbi.
Confocal.
This is wonderful. I love it. Brilliant.
Fantastic.
It's amazing.
Yes, don't forget. Yeah, for those of you who are,
4th to 6th of June.
Yes.
Of confocal and not only.
And not only, of course, skin cancer in
Naples.
general. Yeah, Naples, beautiful city. And of course, I mean it's a congress bringing all the experts of advanced non-invasive technologies all together, and therefore it's a nice opportunity. Yeah.
Debbie, will you be there?
Me? I think so. Yeah, probably.
Depends, depends.
No,
If
yeah.
if Elvira set him free, then yes. Otherwise, no.
Wonderful,
Okay.
wonderful.
Many other things.
Yeah,
Many
yeah.
questions.
What are the indications for imaging around the diagnosis? I guess you mean about ultrasound and so on. So the main indication is an ultrasound of the regional lymph nodes, especially when the tumor is
Yeah.
high risk, but also when the tumor is low risk. Ultrasound is not is an easy to perform exam. All the other techniques are indicated only if there is a sign which justifies this,
Yes,
not baseline.
maybe it's nice to clarify that squamous cell carcinoma is much more an easier guy than melanoma because squamous cell carcinoma only in 5% of cases, not more than that, is going to give recurrence and eventually first lymph node metastasis. Always as a rule, if it's going to give metastasis first, it's the lymph nodes, and therefore the follow-up is only related to the ultrasound of the regional lymph nodes. And eventually afterwards, I mean, in 2% of cases, patients are dying. There is someone who's saying that 2%, it seems to be not so a very high number, but since squamous cell carcinoma is very, very common, 2% means that
Many people.
probably many people are dying as much as melanoma
More.
patients are dying for melanoma, and even more. Yeah.
Mhm.
So this is an impressive picture.
And
Oh,
just clarify, sorry, just another. So only if you have additional indications should you do a peri-surgical imaging if you think that there might be infiltration of the bone. So a CT
Yeah.
with
Yeah. Yeah. Of
the,
course. Of course.
uh,
In the primary area of the lesion, of course. Yeah. Yeah.
how
But
many millimeters should be the safety margin for keratoacanthoma? That's a difficult question to reply. Theoretically, for the keratoacanthoma, you don't need safety margin, but
1 millimeter.
you're never sure if it is a keratoacanthoma. So difficult to answer question. What about a squamous cell carcinoma in chronic leg ulcers?
yeah, yeah. It
Yeah,
happens. It
it
happens.
happens in chronic leg ulcers or in chronic inflammations in general, chronic wounds, chronic inflammatory diseases like discoid lupus or like hypertrophic lichen or like lichen sclerosus also. And all these squamous cell carcinomas are rather more aggressive than the classic ones that develop on healthy skin. So special attention, of course, there.
This is also important. Do you still excise in the same place there was a keratoconoma after regression? No,
No, no, no, no, no.
no, because squamous cell carcinoma is never regressing. A keratoconoma can do it. So if you see regression, complete regression, it means that this was a keratoconoma and not a squamous cell carcinoma.
Yes.
Mhm. Do you use cemiplimab as neoadjuvant therapy prior to surgery? Yes, we use cemiplimab in many possible ways. So first of all, as the main treatment for locally advanced or metastatic tumors. Second, as adjuvant after high-risk squamous cell carcinomas that are excised and then post-radiotherapy and then cemiplimab, and also as neoadjuvant for tumors that are marginally large, let's say larger than the size that would allow an easy surgery, and then you do first cemiplimab and then surgery. That's also part of the game, definitely.
But let me just add to what you said, Emilios. I think this CPOST study was one of the most important studies in the latest times for squamous cell carcinoma, and it has given us an extra tool to manage squamous cell carcinoma, and this is exactly what makes a difference. Perfect.
Yeah, so that's about the adjuvant treatment after surgery and radiotherapy. Um, uh,
Very nice. In the UK, a lot of well-differentiated SCCs, low risk, are treated with curettage and cautery rather than excision with 4 or 6 millimeter. Is this something that you have come across? No, but it's reasonable. Although The problem is that in order to get all the information concerning the high risk or low risk squamous cell carcinoma, you have to excise the lesion. And therefore, it's very improbable that we are going to make a treatment like this. Of course, we are not speaking about, let's say, big elderly people like 95, 98, and 100-year-old patients where we have to be more conservative, of course, and therefore, in these cases, we often use curettage.
Yeah. Or also in keratoacanthoma-like tumors, sometimes at least we do it, we shave them. I mean, and then, so it's a similar situation with the one that Shin describes. The problem is that when you do it, you have to be prepared that once every, I don't know, every 20, every, I don't know how many, you're going to have a bad surprise because it's going to be a real squamous cell carcinoma that will recur if you don't excise it appropriately. So this conservative management carries definitely some risk.
There's a really nice question by Priscilla. If you have a cancerization field with a lot of hyperkeratotic lesions, but not infiltrated bases, do you perform excisions of the suspected lesions first or treat with 5FU and then surgery of the lesions that persist or recur? And I think this is a wonderful question. What I usually do, if they're extremely hyperkeratotic, I give urea 40% for 20 days with occlusion. Then I see them, then I treat with 5FU, and whatever remains, I take out.
Yeah. Yeah.
Reasonable.
Absolutely.
What truly drive metastasis in SCC? Tumor-related factors or host-related factors?
Nice
Both.
question.
Both. Very nice. I
But
mean,
if you had to choose one, which one would you choose?
immune suppression. That's the most important one.
Immune collapse.
Yes.
So, yeah, for some reason.
Yeah.
I
And
mean,
of course, I mean, some of, for example, there were a couple of questions about tongue, lips, and so on. These are very aggressive squamous cell carcinomas because they have to be considered like head neck cancers, not anymore squamous cell carcinomas of the skin, you know. So, and these are more aggressive tumors that should be treated in the context of a head neck unit, let's say.
do you see these factors for squamous cell carcinomas in patients undergoing treatments with biologics for psoriasis and so on?
I don't care. I don't care. I don't care about biologics. If they're doing biologics and they get a squamous cell,
Same thing.
same, yeah, they
Yeah.
can.
Although I think that there is theoretically the percentage of non-melanoma skin cancers is a little bit increased in this group of patients, but
this is probably not related to the biologics. This is related to the probably to previous UVB therapy.
Or staying in the sun in order to diminish
yeah.
the psoriasis.
or immunosuppressants, because for a classic, so for cyclosporine, we know it that it increases the risk.
Yeah.
For non-melanoma skin.
Hydrea, the drug Hydrea is really increase the risk of developing squamous cell carcinoma. Hydrea.
In hydroxyurea.
Hydroxyurea, which is used for
Hydroxyurea.
Yes,
Yeah.
that's a different
Or
topic. This is for
hematologic malignancy.
hematologic patients. Yes.
Polycythemia vera.
Yes.
Yeah.
Those are extremely difficult patients.
Yeah,
My
yeah.
worst patients. I don't know what to do with them. I give niacinamide. I give.
Yeah, let's clarify. The hydroxyurea is used for
Hematologic malignancies, for
Yes,
erythropoietic,
especially for
polycythemia vera.
polycythemia vera.
polycythemia vera. Exactly.
Especially this drug induced the development of SCC in patients who has severe sun damage because it activates RAS pathway.
There's a beautiful question that I have thought of myself, and I don't have the answer. SCC is often painful. BCC not. Is that your feeling?
Yes.
This is my feeling, but the thing is that very often you will excise a squamous cell carcinoma that hurts, and you will expect it to have a perineural invasion, but it doesn't. And I don't know why squamous cell carcinoma hurts, whereas BC does not.
Yeah, but it does have perineural invasion when it hurts. It's just that
It's very-
histologically they don't see it. So
Exactly. They are not able to catch it, but there must be some perineural invasion,
Yeah, yeah.
otherwise they would not be
So it's a
painful.
matter of pathology, you think?
Yeah. So today, anyhow, the perineural invasion is defined with the three possible ways, and that was in the CPOS study, for example. It was taken into account. You have the clinical perineural invasion, the histologic, and the radiologic. There are three different ways
You're
that
right.
you
You're
can
right.
document this perineural invasion.
And the clinical is pain.
The
So
clinical is pain, of
Yeah.
course. It's
Yeah.
pain or paresis or something like this. I
Yeah.
mean, it depends on the.
Concerning,
We got most of the questions, I think, didn't we?
yes, more or less, but maybe after Sebi is launching the video, we can just have a check.
Yeah. Go, Sebi.
I love this skin. This is something which will change a little bit the way we are taking pictures and the fast downloading process. It's very nice. Yeah. Good. What else? What else? What else?
There is a question about Bowens, which is a kind of theoretical one by Michael, saying concerning progression to SCC. On the one side AK, on the other side Bowens. If Bowens represents full thickness intraepidermal carcinoma, yet often remains clinically stable for years, while actinic keratosis may be more dynamic biologically. Is the distinction truly ontological or largely a histopathological threshold within a biological continuum?
this is a beautiful question.
Yeah.
I
Yes.
love
And
it.
we
Yes.
don't know the answer.
Beautiful question that I have no answer to.
Yeah,
Yeah,
it's
exactly. Same here.
Yeah, it's sure that there are some peculiar characteristics for Bowens. First of all, look where it develops. It does not develop on sun-damaged
Yeah.
field usually. It develops as a solitary lesion, often on the trunk or proximal extremity, so not at the most sun-damaged skin. There is nothing in the surrounding. In fact, they do remain usually stable for years. They don't often evolve to squamous cell. So there could be, we discussed it also in the previous episode, I think there could be an idea of a different pathogenesis, possibly related to the virus more than to sun damage. Yeah, that's all we can say. I mean, do you want to add something to this, guys?
Yeah. No, I agree. Treatment with imiquimod of initial squamous cell carcinoma misdiagnosed as a AK worsens the prognosis of squamous cell carcinoma? No way.
No.
No way. It's a treatment anyhow for squamous cell carcinoma as well. The problem is that sometimes or very often imiquimod is insufficient to treat completely squamous cell, but it's not a big mistake, not at all.
And I'm sure that in these sun-damaged field cancerization problems that we apply imiquimod or fluorouracil, probably some of these lesions that are treated effectively probably might be early squamous cell carcinomas. It cannot be that all of them are only actinic keratosis. Probably some of them are early SCCs that are effectively treated with
Yes.
drugs, of course.
Yes, but let me tell you, the only way to manage very old patients which are in bed, who are in bed, they cannot join the hospital, and they have big squamous cell carcinomas. The only way is to manage them with imiquimod. Very often I use both 5-FU and imiquimod. One is in the morning, one in the afternoon, and I keep them in some way controlled, so at least they don't grow, let's say, uncontrolled. So it's a good treatment anyhow.
I have a great case. Give me just 1 second. Need to find it. Go on, go on.
Yeah.
I will come back very soon.
Yeah. For high risk SCC, the tumor depth should be more than 6 millimeter. Yes, you're right. So let's recap the risk factors. 2 centimeter as clinical size. Yeah. So two centimeter clinically and 6 millimeter histologically. And then there is the differentiation, poor differentiation. Then there is the invasion of the subcutaneous fat. Of course, I mean, this is related to the thickness, perineural invasion, immunosuppression, and what else? That's it.
That's it.
Involvement, of course.
Yeah.
Involvement, localization.
Yeah. Location of the lesion. Okay. 4-6 millimeter margin, is it clinical or histopathological? Clinical. We always speak about clinical margins. So 4, 5, 6 millimeter clinical margins. Okay.
Wonderful.
Perfecto.
Are you going to show
Costantino?
something?
Yes, I want to show one beautiful case.
Yeah.
Give me just 1 second. So you see this patient, right?
Yeah.
You see all these lesions, hyperkeratotic,
Yeah.
talking to what we're discussing before. And this is the patient 1 month after urea, pure urea.
Yeah.
Okay, nothing.
Yeah.
Everything is gone.
All
So
Yeah.
there's one thing left. Sorry,
10% urea or 40% urea?
40% urea. There's this tumor left here, which is a squamous cell carcinoma.
Yeah.
The rest we can treat with 5-FU.
Yeah.
And most likely there are squamous cell carcinomas there, but it will go just great.
Yeah.
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 Bene. Allora,
When do you do MOS in Europe?
When
That's a
we have it
very
available.
general question. Yeah. Well, let's say in high risk BCCs and SCCs, but it depends on the availability. It depends on the the resources that you have.
But
perfetto.
regarding MOS, it's very interesting that there are several studies from the US showing that MOS is really effective at lentigo maligna compared to standard excision.
Lentigo maligna.
Yes.
Okay.
Bene.
Mainly the strongest evidence is about high risk BCC, I would say.
I agree completely.
And dermatofibrosarcoma protuberans.
Yeah, also
And
protuberans.
DFSP. So what do you do with DFSP, Jeppy?
Yeah.
Yeah, that was not very informative.
No,
We
DFSP
don't
is
do most. We don't do
why?
most.
Slow MOS. Yeah. For DFSP, slow MOS. Yeah.
Slow most, yeah. But usually,
Why not?
yeah, slow most is a good option. But usually we go with this 3 to 4
Wide
centimeter.
exterior.
Yeah.
Wow.
Yeah.
It's a pity. Why? It's too much.
Well, but
the-
the point that we saw so many of these
Recurrence.
lesions recurring so frequently. It's such a pain.
But
Unfortunately, the patients are generally very young with DPCP,
Yeah, I
and
know,
when you
I know.
excise with the 4 centimeter margins, there's a
Yeah.
big scar tissue there.
I know.
yeah, but if it is with full margin control, then you have very good chances of not to recur.
Yeah.
So it's, in my view, it's one of the examples that makes the maximum sense to do it,
Yeah.
because come on, 3 to 5 centimeters is an
Yeah, it's
unbelievably
crazy.
large area.
Yeah.
So, yeah,
I think it depends on the setting. So I had very recently 2 patients. One, a male, 40 years old, a little bit overweight, with DFSP on his belly. There, I went directly and not having the means to support a slow MOS,
Mhm.
So there, I went directly with, I called the plastic surgeon. I told him go to the fascia, like cut everything, 3 centimeter margins, and it went great.
You made him happy.
I made him happy. But then there was a lady, 32 years old, with a DFSP here.
Yeah.
Oh, yeah.
Yeah. So then I went with slow mo. So I think that it's a bit
Mhm.
trend dependent.
Yeah.
Yeah.
Does the patient apply 40% urea to the entire scalp? Well, I mean, okay, yeah, provided that there is extensive hyperkeratosis, yes, but not to the healthy scalp, because because it's gonna be kind of
Yes. No. He has to apply it on the lesion.
only on the
lesion,
hyperkeratosis.
because otherwise it's a disaster for the healthy skin, for the non-hyperkeratotic skin.
Yeah. And of course, it could be even less than 40. It could be even 30. Yeah, it's
Yeah. Well,
like-
I'm a lover of salicylic acid. So I use 20% salicylic acid.
you can combine them, salicylic
know.
acid and urea.
And you burn the entire scalp.
Yes.
That was what we used in the past, mainly for all these plantar, extreme hyperkeratosis that you want to destroy everything.
Yeah.
10% salicylic acid with 40% urea in Vaseline.
Yeah.
Then you destroy everything. It's not good.
No stratum corneum anymore.
The patient can walk for 20 days, but still, it works.
For BCC, high risk is enough to have clear margins. Well, that's a big discussion. Yes, the big answer is yes. So I don't see any scenario in a BCC that you have clear margins and you need to reoperate. So when you have free margins, it's okay. Of course, you have to keep in mind that the free margins under conventional histology might sometimes be false free.
There is always a bias.
If I can comment on this, the huge problem with high-risk squamous cell carcinomas is that superficial basal cell does this, nodular does this. The difference with high risk is that they do this and this. So, in order, especially in high-risk zones that you do not want to re-excise, so you have a high-risk BCC on the face and you have a 1 millimeter clear margin, maybe you just re-excise. It's okay. But in nose, eyelids, lips, all those cases, what you need to do is to ask your pathologist to do step sectioning, make sure that you have absolutely clear margins, because what we do not understand as dermatologists is that within the workload of a pathologist, for a basal cell carcinoma, they will take 3 cuts. They will see clear margins, and that's done for them. And I understand it from their point of view, but from the clinical point of view, in these kind of cases, you should ask step sectioning, I think.
Yeah. Exactly.
Perfetto. Allora, today we don't have Darius cases. So we can go immediately to Penelope,
Of course.
I suppose.
Of course we can. So here we are, episode 9, starting with the first case on the face close to the nose, a pink nodule for 1 month. That's dermoscopy. You see hyperkeratotic a lot with vessels. Well, quite,
Hairpin,
quite
Yeah.
evident, but mainly hairpin. Yeah, quite many. So
Keratoacanthoma, maybe.
keratinizing tumor, keratoacanthoma, seborrheic keratosis.
Sep K versus keratoacanthoma.
Keratoacanthoma.
Very good. Yeah, so horny surface plaques, complex loop vessels, arborizing vessels, ulceration, blood spots, seborrheic keratosis.
Careers.
Yeah, reasonable,
No.
reasonable. Based on
That
dermoscopy, that was
thick branched vessel is interesting for
No.
inverted follicular keratosis.
But what is interesting to me is that there are many patients that come with this irritated subcase that say that it has been present only for 1 month.
Yeah.
What happens? It's like an immune response that makes it go
That's
up.
why history is irrelevant.
79-year-old man, verrucous nodular plaque for some time on the thigh, similar criteria. Again, hyperkeratotic lesion, masses of keratin, small vessels, mainly hairpin, not only white shiny lines, by the way.
A lot of white continuous areas. I would go for it.
This is more ugly, more ugly.
More ugly, but the same differential diagnosis, I would say.
Yeah, SCC.
Inverted.
Yeah, same differential diagnosis with polarized light, maybe a few more milia, but okay. That's a keratinizing tumor, so it does not
It's
do
too
much. In the end, yeah, thick mass of keratin, shiny white lines, radial. In the end, again,
same.
seborrheic keratosis, inverted follicular keratosis, of course, looking like squamous cell. Case number 3, pain, past history of non-melanoma skin cancer, skin-colored nodule, tender to palpation and spontaneously painful on the arm. Recent onset, dermoscopy does not help a lot here, just white color.
Yeah, we have to remember the tumors which can give pain, and you can remember with the formula penis.
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 I didn't know the penis. I know the.
There are many formulas.
Tell me, what is penis?
Well, penis stands for I don't remember anymore.
I remember the Bengal.
Pilomatricoma.
Pilomatricoma.
No, pilomatricoma.
No, pilomatricoma. It's nevrinoma. It's
neurinoma. It's
neurinoma. Angiolipoma.
Angiolipoma. Yeah.
Glomangioma.
Glomangioma, of course. Yeah.
Blue rubber bleb.
Is this painful?
I think so.
Yeah.
Yeah, I don't remember the rest. I mean, the resident should remember them, not us.
Syndroma.
No, but
syndrome.
Taha is writing lend an egg.
Lend an egg. Yeah. Lend an egg. Yeah, correct.
Adenoma, yes, indeed.
Yeah. Anyhow, here we have also, it's true that we have also some vessels here in the left part. You see some focused vessels. And of course, this white structureless area. Schwannoma was the...
Yes, schwannoma as well.
Here is the Lenden egg. Here is the Lenden egg. Okay, but where is the schwannoma? The schwannoma is not there.
The schwannoma is a neurinoma from deeper neural cells.
Neurolimoma.
But come on, dermatofibroma, painful. Okay. Va bene,
For
va
me,
bene.
just glomus tumor is painful.
Very good. Next one. Again, hyperkeratotic solitary erythematous plaque on the angle for 4 months. That is the clinical. That is dermoscopy with a lot of purpuric dots and globules. plus
Like an iris.
orange, so not
Like an
difficult.
iris.
Very
Purpuric,
nice. Yeah.
purpuric. Think like an
PPD.
iris. Yeah.
Yeah.
Okay. Fine. Beautiful example.
Like an iris.
And then case number 5. Past history of numerous normal melanoma skin cancer, severely for the damaged skin, explosive nodule. Okay, a lot of white color, follicular,
SCC.
perifollicular
Squamous cell
white
carcinoma.
color.
DF.
SCC.
Should be a well-differentiated squamous cell, reasonably speaking. Yeah. Non-polarized light, okay, few more milia, but it's a keratinizing tumor, so no problem. So white circles, central amorphous mass, okay, coiled vessels, clear cut, as it looks, it is in the end what it looks to be, well-differentiated squamous cell carcinoma. Very good. Thank
No,
you.
thank you, Penelope. I'm sorry. I have to make a change. It was not penis. It's glande, which means glands. Yeah.
Grande penis.
Glans penis, glande.
Confused a little bit the terms.
Plants, exactly the
Confused the
same.
terms, but you were remaining in the same area, so it's
Can you imagine how old I am? So, glomus tumor, leiomyoma, okay? Then angiolipoma, angioleiomyoma, angiosarcoma,
Adenoma.
neuroma, okay? The stands for
Dermatofibroma.
dermatofibroma, but I don't know why they put a dermatofibroma into the list. And E stands for ecrine spiroadenoma. Okay?
Okay. By the way, guys, since this is our kind of confession and recapturing our week episode or whatever time of the week, I just like 2 days ago I had a patient and I was devastated because I saw that case 3 years ago and I told him to go away. Like I will find the dermoscopy and show it next week. Literally nothing there. But he felt a bump. Okay. So I dismissed it, told him to go away. But he was thankfully, he was annoyed by it and he went to excise it, to a plastic surgeon. And I saw him now 3 years afterwards with a nevoid melanoma, 11 millimeter depth, 46 mitosis, and he's still on adjuvant treatment. He took out 46 lymph nodes. 10 were infiltrated.
Sorry, I missed something, Konstantinos. At the initial presentation, the tumor was not there. Just the
It was just
just
small pigmentation, like nothing.
There's no plastic. It's very difficult because it's just like pink lesion.
melanoma.
Nevoid, fucking
Nevoid.
nevoid melanoma.
yeah.
Yeah.
Nevoid or desmoplastic?
Okay, nevoid.
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 Can you recall the situation that you did? What you
I
did 3 years ago?
absolutely can recall it. He
Yeah?
came, he had a nevus that was very unsuspicious. I will find it and show it next week. But he was worried, thank God. And he went to take it out.
Yeah, but don't worry. I mean, we all have these cases.
Yeah.
Yeah.
The-
We have shown them. We have shown them to you, I guess, probably.
No.
And to many
Well,
other
but let's say so. We don't have to finish the episode like this. We have all these cases, but not you guys. You will never have a patient like this.
Absolutely.
I swear.
because you are clever enough to learn from our mistakes.
Yeah.
One is that, and two, they will end up to us afterwards.
Yeah.
Yeah, because you know which is the definition of being an intelligent guy.
Send it downwards.
No, you're intelligent when you learn, not from your own mistakes. That
From other
makes you
people's
clever. What makes you intelligent is to learn from the mistakes of others.
Yeah, yeah.
Yeah,
So that's
exactly.
the best thing you can do. Okay. After the philosophy part, should we go
Wonderful.
go on with a Kahoot?
Kahoot.
Okay. Okay. Let me. Okay.
Is it difficult or easy?
Hey, Nisa, I
Ania?
stopped trying to predict. I stopped. I have no idea. My answer is that I have no idea. We will see in a few
We will see,
in
and
a
we
few
will comment.
minutes. We will know if it was an easy or a difficult one.
Yeah.
Let's see.
But I love this idea of group therapy that we're doing.
Yeah.
It's only my ache of this week.
Okay.
It's us and 300 people. Small circle.
Yeah, it's a small circle. But all in good, in good spirit. Okay. Should we go? In my view, let's go. We have
Yes.
many players.
Yes, go, go, go.
We can go. Very good. Episode 9 of season 5. And that is the first case. That is the clinical. Why is this so small? The image. I don't know. Anyhow.
Okay.
True or false? This is simply a seborrheic keratosis. True or false?
Pam, 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 pam.
Is this easy?
Easy.
Not easy completely, not completely easy. I would say true.
Okay.
False.
Okay. False. And
It's a BCT.
we marginally have the correct answer voted by the majority. So it's probably
The
Nasal
one
sound.
area, it helped.
So if you have two possible answers and the result is 50-50, then what is the conclusion? By the way, guys, this was a squamous cell carcinoma, and
really?
in our population, it's rare. Unlike Nisa's population, I know that they see many pigmented squamous cells, but in our population, we don't.
I would vote for basal squamous. I would vote for.
Yeah. And
it looks like a basal squamous.
Yeah, no, it was a purely squamous cell carcinoma, purely squamous.
Great case, a really great case.
Yeah, and I'm not sure if this is pigment or blood, but
maybe there is a combination of pigment and blood.
Yeah, for sure, some of them are blood spots, but some others I'm not so sure. Not so sure. The point is that there is nothing.
Tumor islands.
Yeah, there is nothing convincing for seborrheic keratosis here, so it's reasonable that it's not a seborrheic keratosis. And we have BCC lower leading, followed by Bartek and MW, which brings us to case number 2. That is the clinical, that is dermoscopy. And the quiz asks about the diagnosis, with possible options being nevus sebaceous, hydrochistoma, BCC or SCC.
So for the moment, I'm -1. Let's see if I'm going to 0 now.
Wow!
Nevus very good. Yeah.
Fantastico. 98 correct answers. Dr. Siller in the first place, Gaha and Enzo in the second and third, which brings us to case number 3. That is the clinical. This is dermoscopy. And the question is true or false? This is simply
This is
a seborrheic
I get
keratosis. True or false? True. Okay, very good. This was a seborrheic keratosis, probably clonal subtype with coiled vessels, with clots, pigmented clots, but with a sharply demarcated border. So clonal seborrheic keratosis, very well recognized by the majority of the people, which brings to the first place Gaha, followed by Dr. Siller, and the Navigator in the third place. Case number 4. History of breast cancer, previously treated but not now, previously treated with hormonotherapy. And there is alopecia. That's the dermatoscopic picture. And the question is, dermoscopy shows evident signs of areata, female pattern hair loss, so androgenetic alopecia, anagen effluvium, or trichotillomania. And the correct answer is wow, good,
Yes.
good.
Yes.
I was not sure if this would be.
Why? No.
Okay.
Yeah.
Good, because I'm insecure and I don't trust anymore myself and my,
No, this was
Okay, so we
very
have
nicely shown. Yeah.
signs of female pattern hair loss, mainly the fact that you see that from each follicular unit we have only one hair, so that's
vellus hairs.
very strongly present. Then also some vellus hairs. Of course, we do have also yellow clots, but remember that yellow clots are not a specific sign for alopecia areata. We see them in alopecia areata. We also see them in androgenetic alopecia. So all taken together, the signs favor the diagnosis of female pattern hair.
Well, the clinical was clear cut, right?
Yes, it was.
And the clinical,
Yeah.
of course, but okay. Enzo is now in first place, followed by the Navigator and mighty Chitag 59, which brings us to case number 5, the last one. That is the clinical, that is the dermoscopy, and the question is, this is simply a seborrheic keratosis, true or false?
I predict that 70% votes correctly.
That was the correct answer.
And let's see what happened. Only 70, not 70%, but 70 people voted correctly. But you were close. You found at least the number.
X is the number.
So that was a seborrheic keratosis. Of course, not an easy one. And let's see what happened in the podium. Third place for today, SG. Second place for today, mighty Chitag 59. And the winner of the day is
GPL, like the gasoline.
GPL.
Bravo.
Congratulations to GPL.
GPL. Gianpaolo
Luigi.
You're Gianpaolo. Yeah, your previous president.
Well, but he is Vittoria as a family name, so it should be GPV. Who is the winner?
Did we find the winner or not?
Wonderful, guys. Wonderful.
We covered AKs and SCCs.
Yes, now it's over.
Finished perfectly. Thank you, Konstantinos.
Yes, all done.
Thanks to Konstantinos. Great presentation.
Very good. So for the next Sunday, we will prepare something incredible.
Will we?
Yes, yes, yes.
And
We
are you
will
saying
something.
that my presentation wasn't incredible?
No, of course, of course.
Oh, no,
But
it was incredible.
to beat your presentation, we must be incredible. You know.
Okay.
We must
Fair
work
enough.
hard.
Yeah, very, very hard. Yeah. Great, great, great.
Wonderful, guys. Thank you all very much.
So
So who
enjoy
is
the rest
GPL?
of.
We didn't find the
Where-
winner. Yeah, it's
Yeah,
true.
we didn't find GPL.
GPL.
GBL, who are you?
Yeah.
Yeah.
GPL.
GPL wanted to be a hidden hero. He does not want to expose
Hidden hero.
himself or herself to the public. He wants to.
Constantinos, are you GPL?
Okay.
I
Doesn't matter.
was grande.
I was
GPL.
grande.
From grande.
Va
GPL
bene,
is branded.
ragazzi.
Guys,
Baci,
bye-bye.
baci, baci.
Baci,
I love you.
Amrati.
Have a nice
I
week.
love you.
Bye-bye.
Ciao.
Love you so much.
Ciao, ciao.
Bye bye.
Ciao, ciao.